more I remember, you know. And the first time around, it's almost seems overwhelming, but this is actually getting itself down, giving you some of the details to get down to your operational, what you're going to do in the field to help save lives here. So, who's been in EMS 20 years or more? Oh, excellent. Okay, great. So, you'll identify with some of this, but for those of you that are newer, I think to understand where we're at today, we go back in the 1980s. I started as a medic in the Boston area in 1984. And I always joke about, you know, New England is 300 years of tradition and not a day of progress, so it's challenging to work in medicine up there sometimes. But we all did across the country this standard of trauma patients, low blood pressure, 2 large bore IVs, and 2 bags of saline or lactated bringers as quick as we could and transport the patient. And that had a lot of problems with it. We would arrive with patients that were really having pink Kool-Aid come out of their blood when they were bleeding because we polluted it. So what we found with this large volume crystalloid resuscitation was that the body naturally, when we are in hemorrhagic shock, our blood pressure goes down, we have lost the clotting factors, either external or with internal bleeding. They're not in the circulation available to form a clot. What we have left circulating is greatly diminished, plus now it's being used because our clotting factors are there, but they're not activated until we need them. So we're consuming them. So on a trauma patient, very quickly, they lose clotting factors and they use clotting factors. If we dump a lot of saline in, there's nothing in there that helps the clotting factors, but it dilutes what's left, which makes it less effective. And it raises the hydrostatic pressure or the pressure inside the vessels, so that when there is a soft clot formed and we've raised the pressure, we can actually lose the clot that's formed. And if it's an internal, you know, if we tourniqueted the patient, nothing much is going to happen. But when it's internal in this trunk area, we lose the clot, the patient's going to die. So then that shifted into restricted IV volume, permissive hypotension in the early 2000s. And then this optimal research onto what would be the best combination. Is it blood products alone, blood products and fluids? And this all kind of came out of Iraq, Afghanistan. A lot of focus on this. And what was the optimal combination? And by 2010, 2011, there was a consensus based on studies at a lot of civilian hospitals that did the same protocol that blood should be given back in a 1:1:1 ratio of the components of the blood, meaning the red blood cells, the plasma, and the platelets. And those are the 3 main components of blood that we're concerned about. But this is a super challenging thing to do, and this is the way most blood is supplied in this country even now. And I'll go historically what that is, but when you bring a trauma patient in and there's that fire drill in the trauma room and they're pulling out something red like this is actually usually just packed red blood cells. It's rare to go into a trauma center that's got whole blood, which has all the components in it. This is just one part of blood. And so this 1:1:1 ratio improved survival and gave back the patients what they need, but it's completely impractical. Even in the hospital, it's a challenge because we've got 3 separate bags. All 3 of those bags have to be breathed anticoagulant to preserve it, and the storage and shelf life and administration are different on all 3 of those products. Platelets being the worst as far as the challenge, because they're in short supply because it takes 6 donors to make 1 unit of platelets, and it's at room temperature for the storage, so they're only good for 5 days. Then that got us to this point where we had the first one-off ground units at 911 systems that carried blood, which was 2016 Greater Houston area, and then in 2018 we had the kind of monumental thing that laid the template for all of us, which was the Southwest Texas Regional Advisory Council, known as the STRAC. Was a civilian military effort to prove the concept that ground and air EMS could field not just blood but whole blood, do this successfully in a very large EMS region. So the geography of the STRAC, which is based in San Antonio, goes to the Mexican border and is the same geography as the state of West Virginia. So we have rural, urban, suburban, and frontier EMS systems included in this. And it did kind of finally prove the point. There's a method how this can be done. We're not going to lose blood products. We're not going to have any safety issues, and we want to improve outcomes. So the resuscitation products of choice for hemorrhagic shock by the Joint Trauma System Clinical Practice Guideline update with all of these studies and looked at everything over these past 20 years plus is whole blood is preferred. If we don't have whole blood, then plasma, red blood cells, and platelets in this 1-to-1-to-1 ratio. If we don't have that, then plasma and red blood cells in 1-to-1 ratio. This is pretty common, preceding ground EMS for many years. Our HEMS, our air EMS in the US has carried blood products. Some of these go back to the 1980s. Technology, of course, has gotten better for them too with the coolers. The same coolers that you'll use makes this a less cumbersome process, and the warmers have gotten smaller and easier to use. So a lot of these systems, because whole blood really hasn't been available, and even today isn't readily available on all systems, carry plasma or red blood cells or both. So this has been given pre-hospital, but pretty much all by HEMS. Then if you don't have the combination, either or, and then kind of the last least preferred is just using crystallines. There's been, since the years of the war, even recently last year to this year, we've had a few new papers come out from civilian trauma centers that have taken to using whole blood as the resuscitation product, the initial resuscitation product, and it's proven out that it's increasing the 24-hour survival of these trauma patients better than even doing the 1-to-1-to-1 ratio, and it's certainly simpler because the product's in one bag. This is a sample of our transfusion guideline in the system I work in, and it's based on certain parameters. And I always say when we give talks or we train, we built off of San Antonio, and then like systems like Onslow adopted the same, and we all kind of share these best practices. So whatever blood system you work in, and there's only, like I said, about 100 of us, tend to follow somewhat of the same template that you really want to select your patients that have signs of massive trauma, hemorrhage. They could either be traumatic or medical. And then look at some physiological parameters, heart rate, blood pressure, and certain contraindications. And these will vary by systems. And I think maybe, David, if you want to talk about where Cumberland and this system is going with.
So the indications for our system, and when I say our system, I mean collectively us, is going to be if they have a shock index greater than 1, and I think Dr. Pettini will talk about the shock index a little bit later. But if they have a shock index greater than 1 and you suspect that they're in hemorrhagic shock, then you're going to go ahead and give a unit of blood. You're not going to harm a patient with a single unit of blood. So if you make that decision, and we'll talk about a little bit about what the hemorrhagic shock is, that's going to be our indicators. We're going to keep it very, very simple. Shock index greater than 1, suspected hemorrhagic shock, either visible because there's a huge pool on the ground, or if you suspect it because it's all internal. We will also use it in traumatic arrest in combination with some other things that we're going to add into the system. And then we're going to use it for trauma to start. We will add a medical component a little bit further down the road. And our protocol is going to be ages 2 and up. So from a 2-year-old and up, you can give it. We'll show you the protocol here in a little bit. Anybody less than 2 years old, you'll have to call the PEDS ED and talk to one of their providers. Dr. Wells doesn't want us to call the adult PIC about a kid's patient. So if you have God forbid, you have a 0 to 2 that is in a hemorrhagic shock state, you'll have to talk to the PEDS ED, whoever that particular PIC is.
What's the youngest you did in Onslow?
We did 3. We did age 3, and we gave it to a child that had been mauled by a pit bull, and had basically his abdominal cavity completely tore open, and I think he had probably 4 or 5 surgeries, and he's alive today. He had a 50 or 60 over 0 blood pressure. and completely unresponsive originally. Got flown to pediatric center.
It's a tough case. And we allow for a lot of judgment. You know, we put those guidelines up. We don't use shock index. A lot of the other systems use shock index, and that's your heart rate or your systolic blood pressure. And anything above 1 indicates there's a need for transfusion, that they should probably transfuse. We use it as kind of a guideline and how they do. So, you know, one of the things that you have to be aware of with shock index is that if heart rate is artificially suppressed by medication, on your medical patients in particular, you're not going to get an accurate shock index. So a lot of our GI bleeds that we've treated are on beta blockers. So the shock index isn't quite as meaningful as what it doesn't stop a medic. Like if we were to use a shock index, and there'll be a way here, you do the same. But when you're doing data collection too, we look at shock indexes, like when I'm doing this with the South Carolina system, we tag everybody who's on beta blockers so they understand where they are at. One of the things that sometimes is controversial is, you know, using blood on traumatic cardiac arrest. At least, I don't know, when we fielded it out, our system was a little different. We had support of our hospital and all of us in leadership, but the state, again, our 300 years of tradition just basically had a stroke when we rolled out the blood program unannounced, so we had to fight that battle. And bringing all the other stakeholders, and of course we've got like Yale University and all these other academic centers. I think they know better than everybody else. And our whole stance was, the minute these patients get to our hospital, whether it be a massive GI bleed or a trauma patient, you know what we're doing? We're transfusing them as quick as we can. So why are we letting paramedics do this when it's got proven out nicely for us from all this military experience? So all that being said, one of the things that some of these trauma centers have said is we don't want the medics using blood for traumatic cardiac arrest because the survival rate's so low. And we're like, well, it doesn't tend to get any better if you don't try in any new interventions. You know, just because you're not doing it and it hasn't been done doesn't mean it doesn't help. And this is one anecdotal case that I think is pretty inspiring from San Antonio.
A firefighter says she would have died, but one San Antonio woman is now thanking the people who saved her. According to the San Antonio Fire Department, Tiffany Kieschnick is the first person in the nation to suffer traumatic cardiac arrest, given whole blood on scene, and lived. Trauma cardiac arrest is usually a death sentence.
Thanks to first responders, she is alive today to tell her story. The night team Sarah Costa with the moment that she was able to hug her heroes. That I would not be here without them.
Tiffany Kieschnick only expected to run a quick errand at a gas station near her home. She ended up in this mangled mess of metal on Gulm Road. Our Sky 12 cameras captured the crash last month. Her 13 and 9-year-old sons realizing it was their mother while watching KSAT.
I started praying that she would make it.
Doctors believe a stroke caused her to lose control of her car and flip into a ditch. Paramedic Jason Aguilar with the San Antonio Fire Department was one of the first on scene.
I thought for sure she was done.
With multiple fractures, broken bones, a punctured spleen led to major blood loss. But Tiffany survived. The fire department was able to deliver life-saving whole blood transfusions while in the back of their EMS unit.
By the time that the airlife landed, we had already given her a whole unit of blood. She started to wake up.
Coolers and blood warming devices are what make it possible for whole blood to be carried on EMS units.
The fire department says that 7 units are equipped with whole blood transfusion technology. It's been used 56 times, and the department says that double the amount of lives have been saved since they started this program in October.
Tiffany is the first traumatic cardiac arrest patient to come back to life after receiving whole blood on scene.
I can't thank you enough for it.
Absolutely. You're a hero. You're a true hero.
And Tiffany believes she survived for a reason.
The angels were looking over me that day, and I just feel like I'm back for a purpose. And if I can help them get the word out about the whole blood to save more people, I'm on board.
Sarah Costa, KSAT 12 News.
So yeah, pretty compelling case. She had a ruptured spleen and she got ROSC in the field with traumatic cardiac arrest. So you typically, if there's signs of life, you know, that's when we tell our medics to give blood. If it's a isolated catastrophic head injury, like a gunshot, it doesn't look like it's a hemorrhagic component, and then they go to arrest, we ask them to hold back on the blood. But we've had we had somebody who actually had a young person unfortunately get shot in the head and just had massive bleeding from it, was alive. We gave blood and handed him smarting that night, in our ICU. So we really let the medics use judgment, and like Chief Rodell was saying, we expected once in a while we're going to get a case where blood's given, and we don't find a big hemorrhagic component. Do we look at that and say that was a misuse of blood? No, because it doesn't hurt the patient. We've had one case already where we had a pelvic gunshot wound transverse. The patient had low blood pressure, got blood, pressure came up, went in for an X-lap, didn't find a major vascular injury, just little hematomas. Trauma surgeons were like exactly what we would have done in the ER. So we have no penalty for that, or no, and I never believe that that's the way to do QI anyway. It's like we educate, we get together, we look at these cases, and there's just no way we're going to discourage our medics with their clinical judgment on the spot in that first few minutes at the point of injury. And I say all this just because traditionally, blood is just so safeguarded. If you're in the hospital and you talk to a nurse and they're like, when we start a transfusion, we're going to start this, vital signs cue, 5 minutes, whatever, for the first 15, and we start it slow and we go fast. That's a completely different scenario. We've got patients that are critical. We're just going to get this as quick as possible going. We select those right patients and get the blood in as quick as possible. And it's a very safe process to do. So we're going to go into that next, but I think now would be probably a good time to take a break and go from there.
Take 10.